niet alles schoonmaken op zichzelf. Niet alles schoonmaken. Nee. Weet jij dat in?
Nee, ik heb hem maar. Hij zegt dat mijn OS iets niet genoeg is. Dan zet ik zo mijn...
Maar ik dacht dat er wel in dat soms
mijn presentatie op jou.
Oh ja. Yossi.
Yes, doctor.
How do you like my background?
Yours is very good. But that background still haven't changed. Oh, that's good. That's
Like
very
Indonesian.
It's perfect now, Matis. The background.
It's very good background.
Now we have matching background.
En ze hebben het dan nog leuk op school. Ze hebben het kunnen. Als ze meer naast de schoenen lopen, dan
Yossi,
Yes.
I think Maninki microphone it on together because look like they are very close. So the sound is
because the position is side by side, so I think there's a feedback between their sound of the computer.
Ja, is goed.
No, I think there's a sound, the background sound somewhere. Anna. No. Okay, Dr. Martin, sometimes you need a green background to have a good to put our background better. If you don't have the green one, I think it's okay.
Ja, dat is ook weer goed voor.
Presentatie naar mij. Erop of zo. Ja, dat is sticky, ja. Yossi.
Yes, doctor.
I would like to ask something. If I can have my presentation on the screen.
Okay, Dr. Afif.
And if I can the presenter's version for me and the slide version for you.
Okay, so you want to check your slide first?
I'm just gonna
You want to see your slide?
Yeah.
Okay, Dr. Afif.
Wait. I'm gonna try, okay?
Okay.
Do you see my screen?
Yes, I can see your screen. It's clear. It's very clear.
What do you see now?
There's the two pictures from the lateral side and from the posterior from the front view. There's a small
Melvin, als jij gewoon een dia, ja dit.
Nee, ik...
I think I can see all of your side
hem weggeklikt.
part.
Even kijken, hoe kom ik terug? Oh, ik zie dat.
Afif, Dr. Afif,
Ja?
you help Prof. Nasrun try to log in, but he couldn't come in.
Okay.
Yeah, I'm okay.
Okay, good. Hello. Hello.
Yassi.
Yes, yes, doctor.
I was wondering about the view that you see. If you have only my slide, or also the small slide on the bottom.
The small slide as well, as I already take a picture and send it to you, sir.
Oh. Okay. Yeah, okay.
Did you hear the sound?
Yes, I hear the feedback sound as well.
It's quite noisy.
Als ik hier ga zitten, dan inderdaad.
Yeah, I think it's better. So Maningki move to the other place.
Almost. Yeah. Oh, yeah. Iya. Sudah mulai. Berapa? 200-an. Iya, jalan.
Sorry?
You can start whenever you're ready. Let's start.
Okay. You start with the presentation, or?
We're going to have a
Whenever you
brief
guys are
ceremony.
ready. Yes.
Doctors, we're going to have a brief opening ceremony before continue to your presentation.
Okay.
Here with us already present the Vice Rector of Hasanuddin University, Professor Dr. Nasrul Masih, PhD. The Vice Rector of Hasanuddin University.
You see?
Yes, Prof.
You already start.
We can start whenever you are ready. We can start whenever you are ready, Prof.
Yeah, I'm ready now.
Good evening, everyone. The Honorable Rector of Hasanuddin University, represented by Vice Rector Professor Dr. Muhammad Nasrul Masih, PhD. The Honorable the Dean of Faculty of Dentistry, Hasanuddin University, Dr. Gigi Muhammad Ruslim, MKes, PhD, Aesthetic Consultant. The Honorable the Speakers, Dr. Matis Taufers, DDS, MSc, Dr. Malvin Esmani, MSc, MD, DMD, OMS. And ladies and gentlemen, distinguished participants, good evening and best regards to all of us. Assalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam warahmatullahi wabarakatuh.
We would like to warmly welcome you all today on the first virtual international symposium series that held by Faculty of Dentistry, Hasanuddin University, tonight in theme Surgical Orthodontics Combined Treatment. Ladies and gentlemen, at the beginning of this webinar, we would like to invite Rector of Hasanuddin University to deliver a welcome speech represented by Professor Dr. Muhammad Nasrul Masih, PhD. Please, the time is yours.
Ya. Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi wabarakatuh. Good evening, everybody, especially our distinguished speakers. Dr. Mattis Stalpers, and Dr. Melvin Sebastian Maninki. Nice to meet you, and thank you for your time and for your join to the International Symposium. Please allow me as a representative of Hasanuddin University. I'm Muhammad Nasr Masi. I'm a Vice Rector for Research, Innovation, and Partnership, Hasanuddin University. Actually, this kind of activity is very, we always support all of our faculty in Hasanuddin University. Actually, we have 16 faculty, included postgraduate faculty, and we always support them to do international symposium. And as you know that because of pandemic, COVID-19, so some activity is postponed to the next year, but some activities, they will do it in like a virtual international symposium tonight by Faculty of Dentistry, Hasanuddin University. By this activity, we hope that so many students or clinicians, especially in dentistry, they increase their knowledge and skills. Especially the topic is very interesting because of a surgical orthodontic combined treatment is a I think very updated knowledge. So besides that, we hope that we can increase our academic reputation, yeah, because of we want that Hasanuddin University can be enter next year, because this year 2020 we failed to enter in 2000 world-class university. So that it will cause our collaboration in research, international collaboration in research, and our partnership, yeah, to increase our academic reputation is not so high compared to another university. That's why by this kind of activity we are very happy. Then we hope that this kind of activity can have many activity in Hasanuddin University. And another thing that we hope that besides the virtual international symposium, I hope that this is a series first. Maybe they will continue in another topic, and another department hope that can make it the same like this. And hopefully that so many paper, so many research collaboration can increase, because we have many cases, we have many data, yeah. In Makassar, actually now for the orthodontic, I think is developed, yeah. So many specialized they produce. So that's why I think I saw the participant is almost 300. So it means that this activities will be success, I think. So thank you very much for all of the speaker, for the Faculty of Dentistry, especially the Dean, Dr. Ruslin, and any staff, especially in orthodontic department. And hopefully this can make it more high quality of the education, especially in orthodontic department. I'm a medical doctor too, and I hope that this can increase our, beside the international symposium, any other.
It's mute.
Nasrum, are you still there?
For all the kind of this activity, and we are very support for this activity. Thank you. Assalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam warahmatullahi wabarakatuh. Thank you, Professor.
Thank you, Prof. Nasrul, for a very kind welcome speech. Now we are going to listen an overview of this program that will be delivered by Dean of Dentistry Faculty, Hasanuddin University, Dr. Didi Muhammad Ruslim, MKes, PhD, as President Consultant. Please, the time is yours.
Terima kasih, moderator. Assalamualaikum warahmatullahi wabarakatuh. Selamat malam, salam sejahtera untuk kita semua. Huda and welcome to again join with us in Makassar, but today we do it virtual way because the pandemic reason. And again, thank you very much, Dr. Matis and Melvin, to join with us in our conference, and this time as a virtual international symposium series. And also, I would like to thank you to the rector. In this time, the representative of our rector is from Vice Rector, Professor Dr. Nasrul Masri, PhD, and also he is a specialist in microbiology. Thank you very much for your time, Professor. And today, I would like to a little bit present our surgical-orthodontic experience in our institution. Could you please, Dr. Ivy, to show my PowerPoint, please? This is only overview. So, surgical orthodontic, in our experience in our institution, the prevalence of patients with dentofacial deformities in Indonesia. Could you please slide please? Yeah, thank you. Slide show, please. Yeah, next, please. Yeah, next. Now in the prevalence of patients with dentofacial deformities, especially in Indonesia, we found is the majority of the patients is who underwent orthodontic surgery is young adult females. From our research is mandibular prognatism with the open bite is most prevalent deformity, and also mandibular deficiency was the last prevalent deformity. And the majority of these cases require bimoxillary osteotomy. So they need both technical surgery, maxillar surgery, and also mandibular surgery. Next, please. From our study about dentofacial deformity is based on 3 different sequence analysis, is direct and photography clinical facial analysis, and also with intraoral and dental case analysis. And with 2 parts, intra-arch relationships and also inter-arch relationships. And the second is cephalometric analysis. Next, please. The basic component of dentofacial deformity understanding is dentofacial deformity clinical case can be easier by the identification of the basic components. The first is anterior vertical excess or deficiency. The second is class 3 or 2 sagittal discrepancy and transfer discrepancy and asymmetry. Yeah, next please. So in basic therapeutic goals for the surgery in surgical orthodontic is the first is functions and aesthetic, and the third is stability and also minimizing the treatment time. Next, please. So in the treatment of dentofacial deformities, is reported the most common surgical technique to correct dental facial deformities are, next please, slide please, sagittal split osteotomy and the liver one osteotomy, also anterior segmental osteotomy, the interior intraoral vertical ramus osteotomy, and the genioplasty. This is in our hello.
Are you still there?
Yeah, in this case is so our experience with malocclusive skeletal class 3. You can show the panoramic view before surgery and also one week after surgery and 2 months after surgery and 1 year after surgery follow. In the next slide, please, we can show the cephalometric photograph view before surgery and also 1 week after surgery. Slide, please. Hello. This is our from in this slide is the panoramic view and also cephalometric view before surgery and after surgery. Next slide, please. So that only our overview about our experience in our institution. And so sorry about the signal, a little bit not very good, yeah? Hello? Yeah, thank you very much, moderator.
Okay, thank you, Dr. Ruslim, for the excellent explanation. We hope you get well soon and get better. Okay, we are now entered the main part of this virtual national symposium series with 2 international speakers from the Netherlands that will talk about surgical orthodontics combined treatment. This session will be led by the chairman, Dr. Gigi Yosi Yuanita Aristina Esteban. A brief introduction of the chairman, born in Ujung Pandang, April 6 in 1984, graduated her dentist degree from Hasanuddin University and oral and maxillofacial surgery specialist from Pajajaran University. She is currently a lecturing staff at Oral and Maxillofacial Surgery Department in Faculty Dentistry, Hasanuddin University. To the chairman, please, the floor is yours.
Thank you very much, Dr. Isra. Ladies and gentlemen, distinguished participants, it's an honor for me to lead the session, the surgical orthodontics combined treatment, also most known as orthognathic surgery. We all know that this treatment to correct the jaw irregularities, to improve the patient's ability in breathe, eat, speak, and also to improve the facial appearances. But in the ways of the treatment, as we also know that since it's quite a step to complete this combined treatment, there's always a problem comes along during the process of the treatment from the beginning until the end of the treatment. Therefore, tonight we present you 2 great speakers to explain about these topics. First is Dr. Matthijs Stolpers, the orthodontist who specialized in orthognathic orthodontics. And the second is Dr. Melvin Sebastian Maninki. He is the oral and maxillofacial surgeon who specialized in orthognathic surgery. For the first, I would like to, for our first speaker, I would like to read a brief curriculum vitae of his. Dr. Matthijs Stolpers. Also, he is graduated in dentistry at the University of Amsterdam in 1994. After working as a dentist for 7 years, he specialized in orthodontics. Postgraduate training at the Radboud University Medical Center in Nijmegen and graduated in 2005. Hereafter, he worked as a staff member at the Radboud UMC at the Department of Oral Biology and Orthodontics and started his own practice. Special fields of interest are orthognathic orthodontics, adult treatment, lingual orthodontics, autotransplantation. Since 2005, he is giving lectures and courses on these subjects. As a leadership, he is a board member of the NVOS, Dutch Society of Orthodontic Studies, a member of NVVO, Dutch Society of Orthodontists, member of European Orthodontic Society, and also member of KNMT, Royal Dutch Society of Dentists. Dr. Matthijs, are you ready?
I'm ready.
Okay, please, the floor is yours.
So, thank you very much, Dr. Yassi, for your kind introduction. Thank you, Professor Nasru Massi, and my dear friend, Dr. Ruslan, for having us. Melvin and I are together here in my practice, and we're very happy to organize this this seminar for you. So to all the participants, if I see it well, there are 325. Oh, one guy left, 324 left. So that's a very nice group of people. And especially to you, Dr. Yassi, you did a lot of things in the organization to get everything right. So thank you very much. I understood that we are a mixed group today, so that's very nice. We are dentists, we are oral surgeons, or maxillofacial surgeons in training, orthodontists in training, postgraduate training. So that's very nice. Melvin will be after me on the orthognathic part, and I will do the orthodontic part. For the first two groups, like the dentists and the maxillofacial surgeons, and especially the maxillofacial surgeons in training, it will be, I think, particularly interesting to have a look in the orthodontic kitchen, and especially for you guys, all the surgeons in training, you know, it's obliged to have some basic orthodontic knowledge if you want to team up and have great results on your orthognathic patients. So for the orthodontists, my orthodontic chapter would like to divide in two parts. The first part is really orthodontics only. So we're going to look at class 2 treatments. You know, the good old activator treatments. What are the possibilities? What are the limits? When does an activator patient becomes an orthognathic patient? And so that's the first part. And in the second part, I'm going to give you some practical tips, drills, protocols for your orthodontic treatment of your orthognathic patients. So beware, they will make your life easier. They will make the life of your of all the surgeons easier, and especially you will be able to have predictable treatment outcomes, and that's what makes us all very happy and makes you sleep at night, and that's very, very important. So let's get started. We have a lot to cover. I'm going to share my screen with you. Let me see how this works. You all have my screen, right? Okay. So the orthodontic perspective. First part, orthodontics only. We're going to look at class 2 treatments. And yeah, ask ourselves the question, who is the surgical patient and who is not? You know, the good old activator. We all know it. I have a small animation. Who do we treat? Class 2 patients, of course, preferably with nice arches, with retrokinetic mandibles, and growing patients. So class 2 occlusion after, in an ideal world, looks like an activated treatment looks like this. Class 1, and you're ready for your fixed appliances. So once again, the class 2 patients, retrognathism of the mandible, and growing patients. How do we identify these patients? Well, the old stuff that we learned in dental school or in your orthodontic training. We trace X-rays, we analyze X-rays. So these are some Steiner measurements, SNA, Selanasion A point, Selanasion B point. We're measuring some angles. Let me see, can I put... Oké. Kan ik een pointer aanzetten, Melvin, of niet? Oké. We can measure distances, condylion A, condylion pogonion, or we look at faces. This is a Schwartz analysis from, I think it was like the 60s of last century, 1960s. So we have the Frankfurter horizontal from porion to orbitale, and perpendicular on this Frankfurter horizontale, you have 2 lines, one going down from orbitale, you see it in red in the middle, and one from soft tissue nasion. The pink area is called the Kieferprofilfeld, that's German. It's like the profile field. So subnasale should be in this field, the upper lip touching the front perpendicular line, and you see pogonion, so the chin is somewhere in the middle of this area. And if your face looks like that, you're okay. It's not so hard, but we look at soft tissues, at faces, of course. So this young lad, he has a class 2 occlusion, a class 2 face, has a retrokinetic mandible. So, you know, he might be ideal for an activated treatment. But what about this guy? He more or less has the same overjet as the guy before, but he looks totally differently. He's a divergent growing patient. Well, should he be treated with an activator, or maybe when he's grown up with surgery? What's the best treatment for him? Or this girl, 15.5 years old. It's another story. She is a little bit full on the upper lip, but she has a really retrokinetic mandible, very little growth left. Can we do something with an activator, or should this be a surgical patient? Probably the latter choice. So in general, there are 3 questions to ask. What are the possibilities of the activator? Can we make mandibles grow? Mandibles grow, but can we make them grow even more? And big question, of course, a little bit in orthodontics, especially for oral surgeons, is this long-term stable? We're going to look at 2 researches. We're going to keep it very clinical, basic, practical today, but you know, we have to cover this. The first research is of Kevin O'Brien. effectiveness of early orthodontic treatment with the twin block appliance, a multi-center randomized clinical controlled trial. This is the group of Manchester. Kevin is, besides a vivid fan of Manchester United, he's a vivid researcher, a lot of good clinical research coming from him. If you're an orthodontist, you have to know his name. Please look him up. And he's also a good narrator. So when he's in the neighborhood, he does a lot of congresses. So 2 groups of patients randomized. A young group of patients between 9 and 11 years of age. Half of them get the twin block appliance, and the other half doesn't get anything. That's the control group, and they will be treated later at the age of 11 or 12 years old. What did they see? So look at let's have a look at A point. I don't know how my pointer does work, but I'm sorry for that. What we saw is an inhibition of growth of 0.9 millimeters of the maxilla, in fact. And what they found was extra growth of 1 millimeter of pogonion, so the mandible. Distalization of the upper molars was noted, 1.19 millimeters, and mesialization of the lower molars, 1.52 millimeters. If you add this up and you divide it, you will find that the skeletal part of this activated treatment in relation to the control group, of course, is 41%. And the dental alveolar component, so moving teeth around in your alveolar bone, is 59%. So 60% more or less dental alveolar, 40% skeletal. Well, look at this girl. You should maybe close your pictures on the right side because you cannot see the right side of the screen probably. But she has a class 2 face, class 2 occlusion with an overjet. So ideal patient for an activated treatment. This is, in fact, the activator I use. It's not a twin block, it's called a T appliance. If we zoom in, you have a look at the screw I can activate. But little left of the screw, you see this square area within the acrylic. That's a chip, and this chip measures the wearing time. Actually, it's a thermo-sensitive chip. So after 1 month, when the patient comes back in the office, the assistants goes to the patient and says, "Can I have your activator, please?" And reads the chip. So Yvette, this girl, started wearing the activator, and did it perfectly. 17, 20 hours we see, even 21.72 hours on one day. A little dimp where she maybe had a party or something, but the mean was 14 and a half hours for the last or the first month. So that's perfect. That's very good. Anything more than 12 hours is fine. So after activated treatment, she looked like this. I see a little something that looks like growth in the mandible. If you compare it to the first picture, she looks really different. And this is her occlusion at the end of the activated treatment. So on the day that we would bond the fixed appliances. This really looks like growth of the lower jaw. I know everything knows that the lower jaw is the same as the mandible, but my sisters are watching and they don't know what the mandible is. So hi sis. No, I'm just kidding. So these are the two profiles. So we thought we saw growth, right? No, we probably did. De Vincenzo, the second investigations I wanted to talk to you about. Changes in mandibular length with the functional appliance. Two graphs. So the first graph I'm going to explain to you. On the x-axis, you see the age of the patient in months. This research, you saw it, it's 30 years old almost, from 91. Believe me, I was an adult already in 1991, and we didn't call our age in months. It's given in months over here. Like 150 months is, oh, sorry for that. 150 months is 12 and a half years, and 170 months is 14 years, 20 months later, 14 years and a bit. So when we look at the first measurement on the left side, and we take the upper one, that's the control group. That's a class 1 group, and it has a mandibular growth on the y-axis of 2 millimeters per year. You see, it's quite constant, 2 millimeters, 2.5 millimeters, it goes down a little bit, but it's quite constant growth of the mandible, so that's okay. The group below, with the squares, so to say, that are the class 2 groups. So, and in this case, they started wearing the activators at 140 months. And at 150 months, you see a peak up where the mandible grows for 6 millimeters a year. That's the period of activator wear. Afterwards, you see the fixed appliance come in, activator goes out, the growth diminishes and goes back to the normal level. So very little growth or less growth than the class 1 group. So can we make mandibles grow? Yeah, looks like it. We had 6 millimeters of growth per year. Let's look at the length of the mandibles. So the first group, again, the crosses are the class 1 control group. They start with the length of a mandible of over 101 millimeters. On the x-axis, again, the age in month. So they grow, they grow, they grow, and at 190 months of age, they have a length of a mandible of 109 millimeters. Okay, and now it gets interesting. What about this class 2 patients? They had a length of the mandible of 100 millimeters, a little bit more. Then they started wearing the activator, and you saw this peak growth that we saw on the last slide. You see it happening. And what's surprising is their mandible gets even longer than the mandibles of the class 1 control group. So they have a larger mandible than the class 1 controls, 105 millimeters. The moment we put out the activators, growth diminishes. And it not only diminishes, you get something that we would call a catch down growth. So they grow less. So after a while, people get, the guys and girls, they get 170 months old, so 14 years, they get 16 years. And in the beginning, the difference was about a millimeter. In the end, the difference between the two groups is about 1 millimeter. So yes, we can make mandibles grow. Is it stable? No, you lose almost every extra growth of the mandible. So what do we see then clinical? Let's look at some patients. This is Roos. She came in like this, a class 2-1 with an overjet, ideal for activator fixed appliance treatment. So that's exactly what we did. At the end of the treatment, she looked like this. A nice, pretty girl with a very nice profile. This is 6 weeks after we took the braces off, the fixed appliances off. So nice occlusion, nice interdigitation, everything looks fine. This is 2 years after treatment. She came back, we made pictures, you still see a very nice girl, with a very nice profile. But intraoral, we see a good occlusion still. So the occlusion is stable, looks fine. But do we see a difference in profile? I think we all do. Huh? The lower jaw, the left rows is a little bit more straight than the rows on the right side. So she gets a little bit more convex. The extra growth that we generated with the activator actually is lost. She looks nice. She has a good class 1 occlusion, a good dentition. So it was a good treatment, but we lost the extra growth. And here you see the 3 in a row. So we started with a small rows on the left, and we started with the big rows on the right. So our conclusions on the orthopedic treatment, so to say, class 2 malocclusions can be treated effectively orthodontically with an activator. We can make the mandibles grow, but this is not stable. We're going to lose the extra growth. So this is where we are right now. This is my practice, not all of it, only the right side and the first 2 floors, so to say. So you're looking at this now. If you look at the right side of your screen, you see this little balcony. That's where we are right now, Melvin and I. Melvin, if you, oh, I'm sorry. Melvin, if you go to the balcony, maybe people can see you, but no, it's a picture. It's not a webcam. So, okay. So this was the first part. The second part is about the orthodontic treatment of the orthognathic patient. The orthodontic perspective. We're going to keep it really basic and clinical, so you can take home and have a pen ready. So key steps in surgical orthodontics. So when the patient comes in, you just have a nice welcome and you do your first consultation. We take records like you do, like Dr. Roeslin showed us before. We do exactly what you do. We take records and we write down everything we see. We make a diagnosis in the chair, like we know the occlusion, the overjet, the overbite. Hard to measure on this guy with his palatal bite. We know cross bites, missing teeth, everything. We do our cephalometrics. We make dental casts, of course, models. So that's what we usually do. Then, of course, we have to make a skeletal diagnosis. We do it on the hand of the X-rays, the lateral ceph, or nowadays with 3D, which Melvin is going to talk to you all about. We made 5, to make it easy, 5 subgroup groups of skeletal malocclusions. Okay, these are the 5 groups to make it simple. Classification A is the class 3 patient with deep bite. You all know them. You know them much better than I do, because we hardly have class 3 patients here in Europe. The majority is class 2 patients, but in Indonesia, the majority is class 3. So A and B is what you see a lot. B is the class 3 divergent patient, or the class 3 open bite patient. C and E is what we have here. C is class 2 deep bite, horizontal growers. E is the class 2 open bite, divergent patients. D is the relative class 2. We're going to forget about it today, some other day. So that's the skeletal groups. Okay, so we put this patient in one of the groups. We make subgroups, of course, but we're going to keep it very basic today. Then we have the facial analysis. Okay, facial analysis, guys, everybody listen up now, because this is very important. We don't treat the patient by numbers anymore. We used to do that maybe 30 years ago. We don't. Use your common sense, look at the patients, and what very important to make a good diagnosis is the upper lip profile. What is the upper lip profile? We look at the face, starting at the os frontale. Look at the patient, we look at his nose, and we look at to start with the nasolabial angle. Assess the fullness of the lips. Assess the vertical component, like Dr. Ruslin said. Is there a gummy smile, or doesn't he show any teeth at all? And assess the position of the upper incisors. So the real thought behind this modality is that we assess the position of the upper incisors. As long as we have the upper incisors and later on also, of course, the occlusal plane right, and with your orthognathic surgery, you adjust the mandible to this perfect positions, upper incisors, you will always end up in a well-balanced face. So 2 profiles. You can choose which profile you like best. Make a choice. The left one was drawn by a master painter called Pablo Picasso. Femme en barret rouge, it's called, a lady with a red beret. Yeah, maybe not the most perfect profile, but somebody liked it. It was auctioned at Sotheby's last year, or 2018 it was, I think. It was sold for 50 million British pounds. It's like, I think, 70 million US dollars, more or less. So somebody must have liked it. On the right, we see a good export product of my nation, of the Netherlands. It's our most famous model, Doutzen Kroes, she's called. But there's one problem about her, she's looking to the left. You know, we orthodontists, dentists, oral surgeons, we are a little bit autistic, of course. So we're going to flip her around. So, okay, now we can look at her. We have to, they all have to look to the right. So, okay, as you can see now, we flipped her over. And I put a very simple line on her face. It's going down from soft tissue nasion, and it's perpendicular to the floor. So just a vertical, simple vertical line. This is called, I didn't invent it myself because it's so brilliant that it's so simple. It's called the Barcelona line, and it's made up by the group of Federico Hernandez Alfaro. He's a maxillofacial surgeon from Barcelona, and he does a lot on 3D planning. He is really an outstanding clinician, an outstanding speaker. So please, all the surgeons, write his name down, and if he's in the neighborhood, look him up. Look him up on the internet, Google him, and see his work, because it's really fantastic. The line, follow the line down. This line is supposed to cross the upper incisors, or the upper incisor even can be a little bit in front of this line. In the case of Doutzen Kroes, which has a, well, pretty natural head position, maybe she's a little bit chin up on this picture, but this line is crossing her upper incisor, or maybe even a little bit behind her. And if you adjust the lower jaw to it, she did not have surgery, nature gave it to her, or God, or Allah. But this is what we like today. Remember the picture I showed you 20 minutes ago? This one, it also has a vertical line going down from soft tissue nasion. Here, the upper lip was touching the line. What's very interesting is that this is more than half a century old, and this is from 2010. So in this half century, there is a shift of beauty, of what we think is beautiful, probably. This line, instead of this line, so this line is much more suitable for Asian patients. So you can forget about the Schwartz analysis and take this very simple line. What's very important is that you have your patients in a natural head position. So leave them standing up. Don't make them look to a point on the wall. Just let them put them down and make some pictures, and you will find the natural head position, of course. But this is more how we do it nowadays, and especially for Asian patients, this is very easy. So we have a mixture: dental problems, skeletal problems, facial problems, and everything that's colored red or white comes in the vicinity of orthognathic surgery. Orthognathic surgery can be an option in the areas that are red or white. The dental problems we can fix, orthodontics alone, no problem. So the steps in surgical orthodontics, like I showed you just now. We do a first consultations, records, diagnosis. I put it 3 times because it's so very important. We do a treatment planning session that's just speaking about the treatment with the patient and with the mother and the father and everybody. And we do a combi session. What's a combi session? I always have a session together with, on the left side, the oral surgeon, in the middle, the patient, or right of the middle, the patient, on the right side, the mother. And we speak about this process of the treatment. It's not rocket science. This is just practical work. So then we start treating the patient. Okay. Tip 1, it's as simple as this Barcelona line: bond all teeth. It means what it says. Just bond all teeth. All second molars? Yes, all second molars. I even bond the third molars if they're present in the mouth. I bond all the teeth I see. The reason is very simple. It might look good in the mouth as long as you are doing your orthodontics, but as soon as the maxillofacial surgeon starts moving the jaws around, I bet you will have interferences of your teeth that are not bonded. So that leaves the surgeon 2 choices. It can grind off one cusp of the 3-7 because he has to make the 2 arches fit. We don't like that. And because probably your 3-7 is really nice tooth that can live a lifetime. Or the other choice that the oral surgeon has is that he either can extract the tooth, or he has to make a compromise in where he puts the mandible. So make it easy, just bond every tooth. Then after leveling, aligning, space closure, when you have extraction, you make dental casts. I saw that also in your department already. You're used to do it, and you do it. Let's see one patient, Laura. She has a class 2, division 2, no overjet, a typical class 2-2 case. After leveling and aligning, we made dental casts. So this is her occlusion after leveling and aligning. In my case, it's at 016, 022 stainless steel arch wires. It depends on what kind of slot you use. It can be 1925. I do it at 016, 022 anyway. So this is her occlusion. Frontal side. On the right picture, you see I moved the lower jaw around. I did the BSSO in my hand, so to say. So when I put the lower jaw forward, we have 2 pictures. On the left side, you see the right side of the patient. On the right side, you see the left side of the patient. Let's look at the left picture for now. This is actually what I would like to see at this moment. So we see contact in the front, contact at the second molars, and we see a little space between the upper and lower premolars and first molar. It's very nice. I call it the 3-point contact. On the left side, so on the right picture, you see, look at tooth, what do you call it? The first premolar, 2-4 or tooth 24, probably you call it in Indonesia. 24 and 35. There is
2-4 and 3-4.
Okay, 2-4. Okay, great. Thank you. So look at tooth 2-4 and tooth 3-5. There's some interference. So that's not what I'm looking for. No interferences at all. There might be some light contact. If you think it's okay, it's okay. But if there is really contact and the models are flipping around on this interference, do something. Or you make a step in the arch wire, or you rebond the bracket. So in this case, I would rebond the bracket on the 3-5 and put it up, put it a little bit more to the occlusal. So you have intrusion of your 3-5. What we also see here is that the occlusion is a little bit slightly class 2, a little bit distal occlusion. The front is touching, but the lateral parts are a little bit in distal occlusion. I don't like that at all, as well, I have to say, but also at all. Why not? The oral surgeon cannot put the teeth in exactly neutral occlusion. So can class 1 be obtained? Okay, that's what I'm talking about. If not, here is your little tip or little trick number 2. Look at the area between the lateral incisor and the upper canine, the upper lateral incisor and the upper canine. I put in a coil spring. Very simple. Make a little diastema, 1 millimeter usually. It's enough. Make diastemas on both sides. You see them on both sides. 1 millimeter. So you get a little bit more proclination or protrusion of your upper front. So the oral surgeon in the surgery can put the mandible exactly in neutral occlusion. If you don't do that, you leave the choice to the oral surgeon. You know, they cannot make choices. We all orthodontists know that. It's hard for them. Okay, but don't give them the choice. Either he's going to put them in an overjet of 2 millimeters and you have class 2 on the lateral parts. You don't want that. Or he's going to put the occlusion right in the class 1, but you have end-to-end contact on your incisors. We don't want that either. So just open it, and after the surgery, you can close it again. You can make the choice of how you do it. Tip number 2, very easy. Use open coil springs between, or make diastemas, whatever way you like. If you use some other kind of spring, it's of course all right. Just make a little diastema, 1 millimeter, it's fine. We look at the transverse dimension. That means if you put the models around, look where your palatal cusps are of the upper molars, so to say, and premolars. Are they in the central grooves of the lower? You're fine. A lot of the times we see that they are not in the central groove, but they are a little bit above, in front of the buccal cusps of the upper. So you need some expansion of the upper or compression of the lower arch, but adjusted. And the interfering contacts we were talking about. Okay. We also do, at this point, stage in treatment, re-examination of the face. What do I mean? Is the face going to look nice after treatment? Sometimes it's hard. This is Laura again. This is at the end of, at this stage of 1622 steel arch wire. So where we were just now, and she said to me, I think my upper lip is too full. It doesn't feel natural to me. It's a little bit full. I agree with her. So after talking about this, we decided to extract in the upper, 1.5, 2.5. to make her, to retract her upper incisors a little bit, to make her less full. So afterwards, she looked like this. I preferred this Laura. A little bit fuller in the upper lip, but she really wasn't comfortable. We spoke about it sometimes. So afterwards we did this and she was a little bit flatter. She also gained some weight. And that had to do with another complication. No, it's not a complication. She got pregnant during orthodontic treatment. You know, it happens. She said, I'm going to start, but we also, you know, want to have children. And she's, in fact, she has a boy, a son now, but she was getting pregnant. You know, sometimes happens in orthodontic treatment. You cannot help it. Usually when it happens, it's women that get pregnant. So, you know, it's always a problem. With guys, no problem. You go from A to B. But no, I'm just kidding, of course. She was very happy and has a nice son. Re-examination of the face. This one, same. She looks very nice, but she has a short upper lip and it's really hanging also a bit on her nose. So she had the feeling, okay, is my lip too full? I said, okay, let's make a picture. No problem. One normal picture. On the left side, you know, relaxed picture, and a picture on the right side that we try to make relaxed also, but then with the mandible forward, correcting the overjet. Just put the incisors together. If you make it, you see it, it looks a bit, you know, unnatural, of course, but she said, no, okay, it's good like this. She has a little bit of foregezicht, so it's a little bit in front, but in this kind of face, I would really be scared to take away the incisors behind the upper lip. I mean, what do you leave there? So we just went on like this. Okay. Huh? Yeah, I'm almost done. Some cases. So the key steps again: level and line, dental costs. We do some ortho. We at the end we do put surgical hooks on the wire. I'm going to add a picture for you later on. Surgery. After surgery, the first 6 weeks are very important, of course. I see the patient as an orthodontist 10 days after surgery. And after these 10 days, I see them every 2 weeks. The most important thing is that they wear elastics 24/7. So that is really 24 hours a day, 7 days a week. Always wear elastics. To prevent relapse, of course, and to immediately close the bite. We're going to speak about this also a little bit later on. Post-surgery, usually I need 6 months. I put 6 to 9 months. Usually I need 6 months. Before surgery, I usually need 1 year, sometimes a little bit more. So the treatments, the orthodontic treatments are all within 1.5 and 2 years finished, which is okay. Could be faster, but that's not really that much important. So, okay, let's have a look at a couple of cases and then Melvin will take over. Great, this is Lisa. Class, no, I'm not saying this. What classification is she in? Everybody had it right, class B. So that's a class 3 patient, a little bit open bite. It's not that open, but it's not a deep bite. And you could see on her profile that she was a little bit divergent. So just a little tip for you guys, because you have so many class 3 cases and they're really very nice to treat. If you have patients in this category, so class 3 open bite patients with proclined upper incisors, protruded lower incisors, so that's not, I call proclined is this, protruded is this. Protruded lower incisors. If you see a reversed mandibular curve of Spee, reverse is this. And you see crowding, put in consider extractions, I could say extractions. It's very hard to do this without extractions. You can never make a good curve of P if you have and crowding and reverse mandibular curve of P. So usually extractions. I put consider extractions so you guys cannot sue me if anything goes wrong. This is her Lisa before surgery. This is her Seth. We're not going to go into that at the moment. No. We have to, of course, close the last space, and she's here, and she lost a bracket in the upper, so we're going back to 018 round wire, but this is really almost ready for surgery. This is after surgery, and again, 3-point contact. Look at the right slide, contact in the front and contact in the back. This is 8 weeks after surgery. So we still have to close the lateral parts, but that's okay. And this is her face afterwards. Happy smile, overjet, normal overjet. On the right side, the profile picture, you can see that she still has some serious swelling. It takes 9 months, more or less, to get rid of the swelling. And what we actually almost every, not every case that we treat, class 3 cases, we leave the lower jaw alone. In the first picture, you might think, oh, she needs a setback of the mandible. We only operated the maxilla. In most of the cases, almost every case, that's what we do right now. Don't we, Melvin? He's checking on me. So this is before, this is after. Sometimes, not good. No, okay. We'll another seminar. We go into this deeper. Let's put in the Barcelona line. So before surgery, after surgery, it's going to cross the upper incisor or even a little bit dorsal of the upper incisor. So the same as Dawson Cruz, our famous fashion model. She is still a little bit puffy in the face and a little bit too convex, but this is her 1 year after treatment, and she's less convex and still very happy and a happy student now. Okay, not going to that. You can see that we only did the upper jaw. Lindsay, yeah, difficult. Pretty girl, comes in to the practice, doesn't like her crowding and doesn't like her overjet. She says, I have an overbite, you call it. So these are the 2 problems. But, you know, it's hard. She has a good face. Let's go back one. If you do a BSSO to correct the overjet, you know, the chin is going to be too much to the ventral. So what we're going to do? Well, this is what we do. First of all, in what category is she? Of course, C, class 2D bite. What we do is, and this is are the X-ray, the intraoral pictures just before the surgery. You see the surgical hooks that I put for my surgeon, and the trick is very simple. We keep the bite deep. We didn't level. We kept we aligned. But we did not level the mandibular curve of P. We left the bite deep. So very simple, so to say. If you do a BSO, here's the cut, and we go to the front, we have to go also down. So we make a clockwise rotation of the mandible. So the chin goes down, and when the chin goes down, it doesn't go as much forward, of course. You go like this, you go forward, and you go like this. So in these cases, you can operate on class 2-1 patients, do a BSO, and keep the profile more or less the same. So this is her after surgery, 8 weeks after surgery. The 3-point contact again, contact in the front and at the 7s, and opening of the bite. This is at the end of treatment. Okay, good overjet, overbite, and occlusion is okay. So do not level the curve of speed in class 2 deep bite cases, especially when they're class 2-2 and they have a big chin. It's difficult. So it's still difficult for us. So this is before surgery. You can see because she's still smiling, and afterwards she had to go to Melvin. So this is after surgery. She's still puffy, swollen a little bit. This is at the end of treatment. So we hardly changed the profile, but we corrected her crowding, corrected her overjet, so she's happy. My last patient, a youngster, happy kid. He has this is occlusion. This is your A patient, class 3 deep bite. In class 3 deep bite patients, I don't have to explain this to you because you see them every day. Beware of functional shifts because they will sometimes bite down end to end and shift to the front. So this is X-ray, is lateral ceph, but what you can do in those cases, have them, a wax bite block that we use also to make construction bites and activators, and have them bite towards a nice lower part of the face, lower third of the face. So that's what I did here. If you can see it here in the mouth, you see a nice overjet. Everything goes well. And if you look at his profiles, you see really a class 3 profile on the left. The chin is coming forward, and on the right, yeah, starting to look like a normal class 1 profile. So these are not surgical cases. Might be if you have to down fracture the maxilla and give him extra face height, but not in a sagittal plane. So class 3 patient with deep bite often is a class 1 patient with over rotation of the mandible, and sometimes a short mid face. So we just treated him. I extruded, I leveled. This is occlusion after a couple of months of treatment. Nice class 1 occlusion, easy peasy. And this is his face after a couple of months. Well, this is a little bit later, after 8 months of treatment, and he has a little bit prognatic chin, but he's like a man already. Has a good has a good occlusion, good overjet, and a good face, I think. So thank you very much. This is the orthodontic part. I hope I helped you a little bit. Especially I hope to see you either in Indonesia, in Makassar, or maybe here. On this slide you see my name and my email address, so if you have, don't hesitate. If you have any questions, if you want to have some tips, if you have some tips for me, if you want to invite me to your home, send me an email, stapels@icloud.com. So so thank you very much, and Melvin will take it from here. Thank you.
Thank you very much, Doctor. It's a very great presentation. Actually, we have some question for you in Q&A box, but the answering question session will be conducted after presentation of Dr. Maningke. Is it okay?
I will try to stay awake. So
okay, thank you. Then distinguished participant, we are going. We'll move on to our next presenter. Melvin Sebastian Marinki, MSc, MD, DMD, maxillofacial surgeon, born in Surabaya. So that's why he know how to speak in Bahasa a little bit. Dr. Maninki received his DMD at the University of Amsterdam in 1996. He then studied medicine and received his MD at the Vrije University, Amsterdam in 2001. He received his specialty training in oral and maxillofacial surgery at the Vrije University Teaching Hospital in Amsterdam in year 2004. He is now a consultant of oral and maxillofacial surgeon at the Jeroen Bosch Hospital in Hertogenbosch and the Berenhoven Hospital in focusing on orthodontic surgery and pre-implant surgery. He is also part-time faculty at the Department of Oral and Maxillofacial Surgery of the Vrije University Teaching Hospital in Amsterdam. He is a diplomate of the NVMK, MKA, NVOI, and ICOI. He is a board member of the Regional Dutch Dental Society and MT Midden-Brabant, and member of the Scientific Advisory Board of the Forum for Orthopedic Research. And in his spare time, this is things that I have to mention. In his spare time, he enjoys snowboarding, sports, and fine wines. Okay, ladies and gentlemen and distinguished participants, please welcome. This is Dr. Maninki. Are you ready, doctor? Oh, still set up things. Operator, please highlight the Dr. Maninki's profile.
Yes, no.
Okay, thank you. Please, the floor is
I
yours,
was on
doctor.
mute. Selamat malam. Thank you, Dr. Yoshi, for your kind words and your kind invitation. Thank you, Muhammad, for organizing all of this. Thank you very much. That was a really boring lecture we just had. At the beginning of the lecture, there were 300 people watching. At the end, only 50. And now it's again 400. So it's his fault. No, I'm just kidding. Thank you, Matthijs, for your lecture. And some of our patients we'll see again. I'm going to talk to you about orthodontic surgery, and I'm going to focus a little on 3D planning of orthodontic surgery. We'll start out, of course, with the old-fashioned way with 2D planning, and we'll end up with 3D planning. As you said, I was born in Surabaya, but most people don't believe that I'm from Indonesia. But just to prove to you that I am actually Indonesian, wait a minute, why doesn't this work? Ah, wait. This is what I had for lunch, tahu telur, homemade. So if that doesn't prove that I'm Indonesian, I don't know what does. And being from Indonesia, I also very much enjoy visiting Indonesia, of course. I had the pleasure of lecturing in Jakarta. This is where I first met Mohammed at the Free University in Amsterdam. This is the three of us in the operating theater. The picture on the right is with our dear friend Tim Voorusanvar, the professor of the University of the Vrije Universiteit, when Dr. Ruslin got his PhD. I was lucky enough to attend the ceremony. And of course, a few years back, we were invited in Makassar at the Claro Hotel, talking again about orthodontic surgery. I'll talk briefly about the classification. Matthijs already talked you through it a little, so I'll be very brief about that. We'll talk about classic 2D planning, and then we'll start with the cases with 3D planning. What are the objectives of orthodontic surgery? the main objective used to be a stable class 1 occlusion. If you're talking about orthodontics, the main objective used to be stable 1 occlusion. Often you can get a stable class 1 occlusion with pure orthodontics. But if we're looking at the bigger picture, if we want to have a balanced profile, if we want to have an aesthetic pleasing result, and if we want to keep the characteristics of the face, then often orthodontics alone are not the best choice. And sometimes we need orthognathic surgery. Matthijs talked briefly about the classification. This is the Townsend classification for facial deformities. On the left side, you see the patients with low mandibular angle, and on the right side, you see the patients with a high mandibular angle. On the upper part are the class 3 patients, and on the lower part are the class 2 patients. So this means that dentofacial deformities are divided along 2 groups. You have the vertical, high angle, low angle, and you have the horizontal deficiency or the horizontal problem, either class 2 or class 3. And in the middle, there's a subgroup, which is a high angle open bite. It looks with a dental class 2, but actually a skeletal class 1. These are the tools we have as maxillofacial surgeons. The most tools we use are the Lefort-1 osteotomy. And of course, there are some rules when you're talking about the Lefort-1 osteotomy. You can't move the jaw wherever you like. There's a maximum of 5 to 8 millimeters. Advancement, maximum of about 5 to 8 millimeters. Upwards, downgrafting is possible, but it's not always very stable. And it's very difficult to move an upper jaw backwards. It's possible, but it's difficult. Fortunately, there's almost never an indication to move an upper jaw backwards. If we move the upper jaw, we also move the base of the nose. This means we have to take extra care with moving the maxilla in Asian patients and in Black patients, because we alter the nose. They already have broad noses, usually, not me, but most Asians have a little broader noses. And if you move the maxilla forward, it tends to widen. So we have to be careful with moving the upper jaw in Asian faces and in Negro faces, African faces, sorry. The treatment we do the most, of course, is the bilateral sagittal split osteotomy. So moving the mandible forward, backwards. And what we don't like to do is we don't like to rotate the mandible clockwise. We prefer to, we prefer to rotate the mandible clockwise instead of anti-clockwise. There are some suggestions in the literature that anti-clockwise rotation might be a little more prone to relapse than clockwise rotation. So if it's possible, we like to do clockwise rotation of the clockwise rotation of the mandible. Chinplasty, of course. With the chinplasty, the saw line we make, with the saw line we can, if we move the chin forward, if we flatten the saw line, the chin goes forwards. If we make it more vertical, it goes upwards a little. So we can steer the position of the chin by changing the osteotomy lines. We try to use a very simple classification, and why? It's because we don't really look at all the cephalometric angles and numbers, SNA, SNB. I actually never do any, cephalometrics anymore. I look at a patient and I can tell upfront This is a class A patient, so she probably needs a Le4-1, maybe a BSSO setback. This is a class C patient. He will probably need a BSSO advancement. This is a class B, so he'll probably need a setback and a Le4-1 advancement with canting of the maxilla. And this is a group E, so he will probably need a bimax as well, maxilla with partial impaction of dorsal impaction and forward movement of the mandible. So we don't really need cephalometric numbers to tell us what the treatment is going to be. Furthermore, numbers don't always tell you the true story. If you look at these women, all of them are very beautiful. I'm married, so I would decline all of them, but most men would not say no to any of these women. But if you look at the numbers, they should be really ugly. The one on the left has a class 3. The one left middle is a class 3. Then there's 2 class 2s. Matthijs showed you the picture on the upper right. That's Doughton Cruz. And he told you she's a class 1. He's wrong, but she's actually a class 2. You can see the upper lip, the lower lip. You can see she's a class 2. But what she's doing is what all models have been taught how to look pretty on photos, is what she's doing. She's tilting her head back a little and she's moving and therefore moving the chin forward. So by doing that, you're extending the mandibular line and you're masking your class 2. And that looks better on picture. So you don't see that she's a class 2, but she's definitely class 2. I'm going to talk to you very shortly about the 1-minute tracing. This is the way we have been taught to do orthokinetic planning in 2D. I'll show you this case. This is Paula. She has, of course, a class 2. She's a C group, class 2 with a low angle. Yes, as I said, low angle, class 2, so she's a group C. This is her skeletal profile from the lateral skeletal LSP. What is P? Well, anyway, the lateral projection. We drawn some line. We drawing the front teeth, upper and lower. The outline of the mandible, we draw the maxilla, we draw the orbitale, we draw the sella turcica, and we draw the outline of the face. And then we make some lines. The first one is sella to nasium, skeletal nasium. The second one is the maxilla, where we would do a Le4-1. And the third line is the mandibular plane. Then we can check, and indeed she's 28 degrees between sella nasium and mandibular plane, so she is indeed a low angle patient, but we already knew that based on her profile. Then we draw some lines. This is the Schwartz analysis, which collega Stalpers already mentioned before. So we draw a line down from sella nasium, touching the upper lip. And we draw a second line through orbitale, also in a 90-degree angle on sella nasium. And the Schwartz analysis, oh, wait a minute. We draw where we do the BSSO, and now we can do the analysis. And the Schwartz analysis tells us her chin should be a little more forward, but not very much. According to the Schwartz analysis, the chin is actually in the right position. So if we move the mandible forward, she would actually become a little chinny. As Matthijs told you, this is a patient from, I think, 20 years ago. So in that time, now if we would just move the mandible forward, she would look good. People would say, yeah, that looks good. 20 years ago, people would say this is too masculine. So what we did back then to prevent the becoming too chinny is we asked the orthodontist to keep the deep bite. And when we do that, if we move the mandible forward, you see the chin doesn't change position very much. So we do a BSSO, and because of the deep bite, because of the 3-point contact, the mandible moves forward, but it rotates a little backward. So the net movement of the chin is very, very little. So this is a picture showing you what we mean by keeping the deep bite. The curve of SPI dictates the position of the chin. This is her with a deep bite, and after surgery, after the BSSO advancement, because of the deep bite, if we would move it all the way forward, this is what would happen. So if we level the curve, the mandible moves forward, and it would look like this. And she would be a little too chinny because she has a little bit of a deficient upper lip. She would be a little too chinny. If we keep the bite deep like this, when we move the mandible forward, it rotates. So it doesn't move completely forward, but it rotates backwards a little. So the chin doesn't move very much. And of course, you end up with an open bite, but we have orthodontists to close that for you. And this is what it would look like if we don't level the curve. Now, if we fear it's still a little too chinny, what we can also do is we do a partial impaction of the maxilla. We do a dorsal impaction of the maxilla, and it would look like this. So instead of doing only a BSSO, we do a bimaxillary surgery. We don't move the maxilla forward, we only impact it at the molars. And then you can see that the chin goes back even more. This is what it looks like directly after the surgery. So you have a 3-point contact. You have contact on the 7s, and you have contact in the front. And in between, there's no contact. And this is post-orthodontics. So this is simple 2D planning with what we call the 1-minute tracing. But of course, the world has evolved a little, and 3-dimensional planning, 3D planning, is basically the future. The people want to take the guessing out of the whole surgery, so they want predictions of how will it look 3D. So 3D planning has started in the last decade and a half, and slowly becoming the norm in orthodontic surgery. And most of it started with this article, 3-dimensional treatment planning by Swennen. This is a picture of early planning. The problem with these early systems was that they were all based on occlusion. They were all based on surgical splints. And as we know, the mandible is the only bone in the whole body which has 2 joints. And very often, the position of the condyle is different during the surgery and before and after the surgery. So this means there's an inherent inaccuracy if we use surgical splints. Because when you do the planning and when you do the surgery, the condyle has to be in the exact same position, otherwise you're getting a different result than you planned. So this is the reason why I never did very much with the 3D planning until reports starting to come from China, from Finland, over the last decade about 3D planning not using repositioning guides, but using surgical guides and templates. And the idea was that you don't need a splint to define the position of the upper jaw. And this, of course, makes a lot more sense. I mean, the maxilla is fixed. If you move the maxilla, you can determine the movement exactly, and the mandible will follow. But if you're using surgical splints, you always have the mandible dictate the position of the maxilla, which doesn't make very much sense to me. So I followed this quite eagerly. And this is 2016, a paper from a Finnish group using patient-specific implants to determine the position of the maxilla. And this is when it started to get interesting, in my opinion. So I'm going to talk to you a little about the system I'm using at the moment. It's called the Face Guide. This is a picture of me in Seoul. This is the Dr. Park. He's the owner and the inventor of Face Guide, and is the head of the Megagen group. And we are standing in front of their new building in Seoul. I was one of the first to visit there, and it was freaking cold. And all I had was a small jacket. So when I got there, the first thing I did was buy a really, really, really warm coat. And I looked like a polar bear, but it doesn't matter because it was really warm. So what is Face Guide? It's basically the same as the Finnish groups and the Chinese groups did before. It's 3D planning, but it's a waferless system. So it's based on very precise saw guides and patient-specific implants to determine the position of the mandible and the maxilla. The basis of the system, of course, is a CT scan. So you need a cone beam CT or medical grade CT for your 3D planning. Unfortunately, if you only make a CBCT or a CT scan, the occlusion is it's too inaccurate for an occlusion. So you need an extra data set, either an intraoral scanner or a model scanner to determine precisely the occlusion, because the occlusion in a regular medical CT or CBCT is not accurate enough to do very accurate planning. So you have a CBCT, you have the surface scan of a model or an intraoral scanner, and we combine those two. So you get the skeletal from the CBCT, and you get the fine occlusion from the model scan. The second step is the position inside either a CT scan or a CBCT scan of the skull is not a natural position. They are forced into, well, in a CBCT, they're forced into something which is similar to Frankfurter horizontale, but that's not the normal way people hold their head. So what we first have to do is we have to rotate along the I, X, and Z axis to make sure that the CBCT scan we're planning is orientated in the same manner as in real life. Otherwise, our planning would be wrong. So we adjust the pitch in the jaw. We adjust the roll according to the orbit. The reference line is the infraorbital rim. And we move it to adjust Frankfurter horizontale. Then what the technicians do is they match the STL scan from the dentition. They match it to the CBCT scan to get the very accurate fine-tuning between the CBCT scan and the STL files. So what they're doing is they're matching the position of the surface scan to the two teeth in the CBCT scan. So you get an accurate position of the occlusion inside the skull. That's the idea. Well, this is a picture of one of the technicians doing that. Of course, for me, this is too difficult, so I leave this to the experts. And then we can do a facial analysis. This is their standard facial analysis. I don't use it because, as I said, I don't treat by numbers. I just look at the patient and I have a treatment plan. I work the other way around. Instead of doing cephalometrics and then using the cephalometrics to determine the treatment plan, I look at the patient, I determine the treatment plan, and then I check it with cephalometrics. So I work the other way around. I don't use the cephalometrics to do the planning. I use my clinical view to plan. Oh, the maxilla has to go forward. We need a dorsal impaction. We need a BSSO advancement. Oh, maybe we need to move the midline a little. This I do first, and then I use the 3D program to check the end result. For me, this works better than using cephalometrics to dictate what I have to do. Anyway, if you want to do the facial analysis, you can, of course. And then we have to tell the computer where the saw lines are going to be. So I think this is a biomaxillary surgery. So first we are going to do a LaFour-1, and we need to tell the computer where the saw lines are. So this is standard LaFour-1 saw line. And what you're about to see is the standard BSSO cutting line, because the computer doesn't know where we are going to cut. And now we can do the planning. We can move the upper and lower jaw the way we want it. So we make segments of the maxilla, the mandible, the condyles, and the scallop. And then we can start moving bones around. Okay, anyway. This on the left is the patient we did 2D, and on the right side you might recognize her. This is Lindsay. This is Matthijs's patient, and he lied to you a little. He told you we only did a BSSO, but we didn't. But of course he's an orthodontist. What does he know? Bimax, LaFour-1, BSSO. He doesn't care as long as the teeth get in the right position. He doesn't care what we do. Anyway, I'll show you what we actually did. She's actually a dental class 2, but if you look at her profile, she's a skeletal class 1. So if we would move her to a dental class 1, she would end up with too much chin. Actually, she's already a little chinny. She has a heavy chin already. So the last thing we want to do is a simple BSO, and then move the mandible forward and end up with a class 3 chin. So the first thing we do is we ask the orthodontist, like we explained before, to keep the dental class 2 with a deep bite. The deep bite is very important. So what we get is a slight protrusion of the chin, but because of the outer rotation, the chin doesn't move forward, but the face will be a little more square. So even if we don't move the chin, she will appear a little more chinny. So she will get a squarer face. And this is exactly what we don't want. So this is the planning. So what we actually did, we looked at the plan, and if you see, if we only do a BSSO advancement, she would become a little too chinny. So what we actually did is we did a Bimax, we did rotation of the maxillomandibular complex. So we did a Le4-1. We didn't move the maxilla forward a lot. We moved it forward a tiny bit, and we impacted the molars. So if you do that, and if you then do the BSSO, just like with keeping the bite deep, but by doing a Bimax, you're again moving the chin a little more backwards. And now you can see on the prediction that the chin position doesn't move very much. So the teeth move forward, but the chin position doesn't change at all. This is the face guide system. So what we see here is we see a saw guide. The saw guide tells us where we have to do the 4-1 cuts, and it also tells us where to drill our holes in advance. The same can be done for the mandible. Actually, I don't use the guides for the mandible a lot. I usually only use the guides for the maxilla. This is the 3D planning. The red parts are the overlap between the maxilla and the skull base. So we have to remove some bone in order to make the impaction, dorsal impaction happening. And the system is based on patient-specific implants. So we do the planning, and the company makes plates patient-specific. So if you plates fit, then you know the position you planned on the computer is exactly the same as you're getting during the surgery. So this is what makes this a lot more accurate than surgical splints. We get an intermediate splint just to make it easier for us to reposition the maxilla, but the intermediate splint is only used as help to reposition the maxilla. The plates are what dictates the final position of the maxilla. And quite often, what we find out is that our intermediate splint doesn't fit, or it doesn't give us the right position of the maxilla. So we end up not using the intermediate splint and focusing only on the plates. Then, of course, we do use a final occlusion wafer to determine the position of the mandible. So this is what we get from the company. We get an intermediate wafer, we get a final occlusion wafer, and we get 2 sets of saw guides for the maxilla and the mandible, 4 plates for the maxilla and 2 plates for the mandible. This is a clinical view. So we position the saw guide, we make the saw cuts which are dictated by the saw guide, and we also already make the drilling holes. Same on the other side. And then if we position the maxilla and we put in the plates, if the plates fit, you're sure that the position of the maxilla is exactly the way you planned it on the computer. So there's no guessing anymore. How many of the surgeons have done an impaction of the maxilla and they do a lateral ceph the day after and they look, there's hardly any impaction at all. How many have had that before? Raise your hand. I have. And why? Because it's simple. Sometimes it's difficult to impact the maxilla. You have to make a lot of room for, if you do a large impaction, you have to make a lot of room, and sometimes it's difficult. And when we're measuring during the operation, and we are making reference holes and we're measuring, if it's difficult, we always tend to think, yeah, we had 3 millimeters, it's correct. Because it's difficult, we don't want to fuss anymore and we're in a hurry and we want to finish, so we become less accurate in our measuring. It's human, everybody has that. So I still see it sometimes with my colleagues who don't use the face guide system and they talk about impaction of the maxilla, and then I look at the lateral ceph and I see there's no impaction whatsoever. And this, with this system, you can't cheat. Because if you don't have enough impaction, your plates don't fit. It's as simple as that. This is the occlusion directly post-op. Lateral CEF and BSSO and this is the patient. This is, I think, directly after surgery, or no, I don't know actually. End of orthodontic treatment. And if we project the pre and the post picture, then you can see there's not much difference in the chin position. And the main difference is the maxillomandibular complex has moved forward a little. So the chin has moved forward a little, but that's mainly because of the LaFour one. We also did a little advancement of so the upper lip moves forward as well. Class 3. On the left, we did regular planning, 2D, and on the right, we did a 3D planning. I'll walk you through it quickly. Class 3. So Group A, so a class 3 with a low angle. So we do a tracing again. I'll walk you through it quite quickly. SN, maxilla, mandibular plane, 34 degrees, so she's a low angle. "25 minutes left, so I have to hurry a little. We'll skip this part. So if we would do only a setback, it wouldn't look good. You can see the profile of the upper lip doesn't change, and he would actually become, the chin position would also be a little backward. It wouldn't look very good. So what we do is we do a Bimax case. We move the maxilla forward 4 millimeters, and we do the rest with a BSSO setback. And if we think he's a little too chinny, we can also do a dorsal impaction of the maxilla. Pre and post. And you can see the major difference between pre and post is actually the upper lip. The upper lip is a lot fuller. He's a lot better looking in the mid face. So the LaFour one is very important. If we would only do a BSSO setback, it wouldn't look this good. Final occlusion. This is a patient, actually the same group, Group A, but here we did a 3D planning. We made the saw guides, and as you can see, in the saw guide, we are not using a standard LaFour one saw cut. And why? 2 reasons. By making a step, we're doing 2 things. First of all is if you're making a straight saw cut, you cut a maxilla like this. What will happen if you move the maxilla forward is it doesn't only move forward, but the front teeth will move upwards a little. So by making the step, we're making sure that if we're moving the maxilla forward, it goes straight forward instead of moving up a little. And the second is because we make a very high cut next to the nose, he will become a little fuller in the mid face. This is the second advantage of using the step cut. Mandible. Patient-specific implants, same as the previous patients. And here you can see the intraoperative view with the saw lines, and you can see nicely the step. And by using the step, the maxilla moves only forward and not upwards. and remove a larger part of the bone next to the nose. So you'll become a little more full paranasal. Plates, final occlusion. And this is the pre and post-operative view. This is post-operative. So this is pre and post. And if we take the post-operative CBCT scan and we match it with the planning, and you only have to look at the maxilla, because I didn't use the plates for the mandible, so the position of the mandible is a little different than what we planned, but the position of the maxilla is 100% accurate. It's spot on.
Yeah, thank you.
This is a patient with hemifacial microsomia, and she's very, very asymmetric. And these are the patients which are very difficult to plan 2D. So these are the patients where 3D planning is really, really helpful. So this is the plan. We do LaFour-1 advancement, and we do downgrafting of the maxilla on the right side. And what we also want is we want the mandibular angle to come down. If we would do a regular BSSO, the mandibular angle doesn't move because it keeps stuck on the condyle, and the condyle doesn't move, so the mandibular angle doesn't move. And we wanted to bring the mandibular angle down. So in this case, we opted for a classic overgazer. This is a surgery I haven't done in 20 years, but in this case, this was the only way of bringing the mandible down simultaneously with canting the occlusal plane. This is directly post-op, and this is a picture of a few years back. In the meantime, I've done an osteotomy of the zygoma on the right side. And unfortunately, what we see is that we got a little, she needs work on her nose as well. Her nose is off. And unfortunately, we see a little relapse. What I said before, if we're downgrafting the maxilla, it's not always as predictable as impacting. So we gained a little, but she's become a little asymmetric again. So probably we're going to do another Bimax and now impacting the maxilla instead of downgrafting the maxilla on the other side. This is a class 2 patient with an open bite. This is the preoperative pictures. And we talked about if we want to do do a BSSO advancement, we like to do a clockwise rotation. If we would close the open bite only with a BSSO, what would happen is we would move the mandible counterclockwise, and there are suggestions in the literature this is less stable than doing a clockwise rotation. So we opt for a Bimax, especially because she's already deficient next to the nose, so we want to bring the maxilla forward anyway. So we bring the maxilla forward, we do the impaction of the molars, and then we do a BSSO advancement, and we want some extra chin, so we also do a chinplasty. And as I said before, by moving the saw line of the chinplasty, we can decide where the chin moves, and we want it to come forward, so the saw line is quite horizontal. If we would make it a little more vertical, the chin would go up a little. Saw guides, patient-specific implants. One of the major advantages of doing this is that by doing the 3D planning, you also plan the saw guide, the saw line, and you also plan the drill holes. So raise your hand if you've ever drilled through a root during a Le4-1 procedure? I have. Raise your hand if you've ever, by making a Le4-1 cut, touched one of the roots of the first or second molar. I have. And of course we measure and we try to avoid it, but especially in the if we want to do a large impaction, it's sometimes difficult to miss the roots. There's just not enough space. If we want to do a large impaction, the lower cut is always close to the roots. And by doing it this way, by planning the saw cuts in advance, we can be certain we're not touching any roots. Also with the screw holes, we can be certain we're not touching the roots with the screw holes. This is the post-operative plan. And we can check the symmetry of the chin and the mandible, and you can see it's perfectly symmetrical. This is an intraoperative view of the chinplasty. And this is post-op. Actually, from a purely aesthetic point of view, if we would do only a mandible, a BSSO advancement with closing of the open bite with only the mandible, aesthetically he would actually look better. He would have a lower mandibular angle. The chinplasty would look better, but because of the open bite, we chose to do a Bimax and not do a counterclockwise rotation. The jury is still deciding on whether this is the right way to go or not, but I was trained by Townsing, and if we would do a counterclockwise rotation in his surgery, he would kill you. So that's still in the back of my mind. This is, I think, one of the final patients. This is a very asymmetric patient, a cleft patient. And again, these are the sort of patients where 3D planning can be really, really helpful, because it's very difficult from a 2D picture to predict how the chin is going to look after you do the surgery. It's very difficult. So maxillary deficiency, skeletal class 3, mandibular asymmetry, and you can also see the midline of the maxilla is off a little, so we have to correct that. There's some canting of the occlusal plane. Asymmetric from A to Z, so it's very difficult to do this on a 2D planning. So we do Le4-1, we move the midline to the middle of the midline of the maxilla to the middle by rotating the maxilla a little. This will also help with the rotation of the mandible. We straighten the occlusal plane, and then we do a BSSO setback. So a Le4-1 advancement and correcting the midline, correcting the occlusal plane, and then we do a BSSO setback to occlusion. So this is the after the Le4-1. And this is after the BSSO. And what you can see is that by only doing a BSSO, a lot of the asymmetry is already gone. So the first plan was to do Le4-1, BSSO to occlusion, and then do a chinplasty to remove the asymmetry. But on a 3D planning, you can see that after the Le4-1 and the BSSO, actually it's almost symmetrical. So I didn't do a chinplasty. All I did during the surgery was remove, I did a chin shave on the left side, a little. So no chinplasty, but only a little chin shave on the left. And you can see it's not perfectly symmetrical. The left side is fuller than the right side, but it's not enough to do a chinplasty. So only a little chin shave on the left, and this is the post-op. Not perfectly symmetrical, of course not, but given what how he looked pre-op, I don't think it's very bad. And this is still some swelling after the surgery. This is, I think, 2 or 3 weeks after the surgery. So the swelling will go down a little. So in conclusion, I don't do a lot of cephalometric analysis. I always treat by clinical view. I look at the patient and that tells me what to do. The problem is it's very difficult to teach that to assistants, and you have to have some experience before you can do that. So the 3D planning helps you visualize what you're going to do. So you, it works, for me, it's like a checkup. I do the planning inside my head, then I transfer the planning into the computer, and then this tells me whether my planning was correct or not. The main advantage of FaceGuide is that we can perfectly transfer our planning into the operating theater. So what we plan and what we do in the operating theater is one-on-one perfect. There's no mistakes from the TMJ, which is in another position, the splint, which doesn't fit properly. There's none of that. So what you see is what you get. And because you're planning the saw lines and you're planning the screw holes, it also helps you protect the roots of the upper molars. So no treating by numbers, treat the caricature, but keep the character of the face. A lot of people want to create perfect faces. My view is that you shouldn't do that. You should treat the caricature, but keep the character. If you change the character of the face, if you go to perfect numbers, usually it doesn't work out very well. That's my opinion. So thank you for your attention. If you know a good restaurant in Makassar, please send me an email, maninki@gmail.com, because I really like to try them someday. Thank you very much for your attention. That was it, the last slide. Over to you, Yossi.
Thank you very much, Doctor. It's a very great presentation. And we have actually lots of questions.
Your microphone is off.
Oh. Can you hear me? Is there anyone can hear me?
Yeah, we can hear you.
Okay, thank you very much. Thank you very much. That was a very great presentation of Dr. Maninki. Well, we have lots of questions in Q&A. I myself have a question as well, but I'm going to read the question from the participant first. Okay, the first is from Dr. Iqbal Tua Pandapotan Sirait. Can we actually guarantee, or how do we explain to the parents about the treatment of the activator, the effect of the activator to the mandibular growth? I think it's kind of informed consent to the parents about how the activator can really affect the mandibular growth.
Probably it's a question for me?
Yes, for Matis.
Wait a minute.
Yeah, perfect. Okay, perfect.
All right.
We're sitting next to each other, so one has to mute and the other.
Okay, you have to make a distance, social distancing.
Yeah, social distancing.
Okay.
So the question is, what do we tell the parents? How much growth are we going to get with the activator?
Yes,
So,
actually the question is sometimes the parents maybe need a guarantee about how the activator work, how its effect into the mandibular growth.
Well, okay, yeah. If you are going to be honest, then you tell the patients or the parents of the patients that you can treat the class 2, so you will get a good occlusion and it will be stable also after the treatment. but we cannot really treat your profile. If you want treatment of your profile, you might consider orthokinetic surgery. But if you're happy with a good class 1, a correction of your overjet, a stable occlusion, it's the perfect treatment for you. But you cannot tell the parents, okay, we're going to make your mandible grow 4 millimeters and it's going to stay there. So what I usually say to the parents of my patients, you're going to see some growth of the mandible, but it's not going to be as perfect as you would have with orthokinetic surgery. But you're going to see some growth because everybody grows, everybody grows. We all have forward growth of the mandible, and in the end, is it the activator that does it, or is it just normal growth? In the research that we saw is that you will lose almost every extra growth that we create with the activator. We're going to lose almost everything.
Almost everything.
Yeah, the extra growth. So they will grow, they will have forward growth in their puberty growth spurt, but you cannot promise them we have 4 or 6 millimeters growth. That's not what you should do.
Okay, thank you, doctor. So how long do you think that we could lose all the extra growth?
How long?
How long? I mean,
does it take?
How many years?
Everything?
Yes.
To lose the growth. I don't understand the question exactly.
You said that eventually we're going to lose all the extra growth. So how long will it take to lose all the extra growth?
Yeah, it can take years between somewhere. If you stop using the activator at, for instance, 12 or 13 years of age, you might lose it in the next 5 years. So when someone has the age of 17 or 18, the extra growth will be lost. But the majority of the patients that you treated will look good. They had an activated treatment. They had a correction of the class 2. They have a good overjet of 2 millimeters still. So they will look good. They will be happy.
Okay, thank you very much, doctor. This is the next question is still about the activator. This is from Dr. Sylvia Sitinjak. What is the best range? I think the best age range for the use of the activator.
Okay, the best age. There are different things. The one thing is age, and the other thing is social development. So the age is very simple. The best time to use the activator is in the growth spurt. So when you have the growth peak, that's the best time to wear the activator. So with girls, yeah, it's about 11 years of age. With boys, it's a little bit later, anywhere between 13.5 and 14.5 years of age. That's growth-wise. That's the best period. So girls at 11, boys at 13, 14. At the peak height of their puberty growth. But in Holland, there's also social things. For instance, when they have in the last class of the primary school, kids in Holland will be 11 or 12. It's perfect. They will wear it all day long in school, at night. So the activator wear is very good. So we try to put the activator in the last year of the primary schools. Also for boys. For girls, it's perfect. Because the kids are 11, 12 years old. But the boys, it's actually a little bit too soon. But sometimes, it's hard to have them wear when they go to high school. It's hard for them to, they will not wear it in school. In primary school, they also will wear it in school. So that's why we do it at the last year of primary school. But if the boys are older, if a boy comes into your practice, he's 13.5 years old, and he has a class 2, I would still put in an activator. Is that a good answer to your question? niks meer. Geen connection.
Hello, Dr.
I
Yossi.
think we lost the connection for a bit.
Oh, I think it's a quite very nice answer from you, Dr. Matis. While we're waiting for Dr. Yossi
Yeah.
to get join with us again.
Okay. Maybe we can go on. I can open the Q&A
Yes.
questions and answers.
That will be good. Now I think we're going to Dr. Yanti Leosari question, but she didn't mention to whom this question should be. So either Dr. Malvin or Dr. Mantis could answer, please. So Dr. Yanti Leosari asks whether is there any way to maintain the mandible growth resulted from wearing activator?
Yeah, probably you could.
Yeah, please.
Probably you could maintain it if you would keep on wearing it over years. If you have this, wear it for as much as you can, or whatever your protocol is. I ask my patients to wear it as much as they can, and then afterwards, if you have the good overjet and occlusion, you could ask the patients to wear the activator at night, but you would have to wear it for years. So after a couple of years, you would have to make a new activator to wear it at night. Probably if you wear it until the age of 18 or something, you would keep the growth. But it's a long time.
Okay, it's quite.
Nobody does that.
Easiest way is to just do the surgery. It's more stable.
Okay.
There's one and two options.
That is the best way. Yeah.
Okay, so a little bit break from our presenters. We have actually a question for Dr. Ruslin. Dr. Ruslin, we have a question from one of our participants who would like to ask about the cases that you presented before. There were an impacted of 4A as he remembered that the tooth weren't removed during the orthodontic surgery. Why? And what is the indication to remove and retain impacted third molar in bilateral sagittal split osteotomy?
Yeah, thank you very much for the questions. I think about the impacted molar third is more debating about put out the impacted teeth molars after or during the surgery. I think it's still under discussion, but from our mentor, Professor Tinsing, he always say you can move the third molar when you do BSSO, during the BSSO. And if we put out the impacted molar third, it's more better the fixation. So the mobility, I think, is more stable if we do during in the surgery. And also we reduce the time of the procedures, 2-time procedures if we do before surgery or BSSO to put out the impacted molar third. And if we do during the BSSO, I think it's only we do the surgery directly. So I think it's more simple. And I think Maninki can give some good answer.
Yeah, thanks.
There's a feedback.
the main thing is your method of fixation. If you use screw fixation, it's better to take them out 6 months prior to surgery. If you use plate fixation, you can just do it during the surgery. And I use plate fixation now, so I always remove the wisdom tooth during the surgery. It's much more friendly for the patient. It saves them an extra treatment under local anesthesia, or 2 treatments even under local anesthesia. So if you use plate fixation, always remove the wisdom tooth during the surgery. But if you want to use lag screws, then sometimes it can be difficult if it's an impacted molar to get good fixation, and then it's better to remove them 6 months prior.
Okay, thank you very much, doctor. Can
Yoshi,
we move
your
to another?
audio's out.
Okay. Okay. Thank you very much for the explanation. We have another question for you, Dr. Maningki, about can orthognathic surgery treat the patient with class 3 malocclusion with anterior displacement case, or you have to do the discoplasty first and then continue with the orthognathic? What do you think, doctor?
You mean in cleft palate cases?
With the class 3 malocclusion with anterior displacement case.
I don't know what you mean with anterior displaced teeth. Do you mean anterior displaced premaxilla, or just
The joint, the joint displacement? I think this is the anterior joint displacement. I think this is from Dr. Sahril Samad.
Joint displacement?
Anterior displacement cases.
Oh, anterior disc displacement.
Yes, I'm going to write it down.
Well, anterior disc displacement is not an issue when you do orthognathic surgery, in my opinion. So there's no problem to do the class 3. You don't have to do a disc reposition first and then do orthognathic surgery. I know some older surgeons, namely Wolford in the United States, he liked to do that, but I don't see the point in doing it. The joint displacement is a result of TMJ dysfunction, and it's not a contraindication to do orthognathic surgery, in my opinion. So joint this displacement is no problem.
Okay, thank you, doctor. This is a question from Dr. Trihartanto from Naval Dental Hospital, Jakarta. How to keep condyle on the position when handling BSSO and Leaford 1? Furthermore, in hemifacial microsomia case.
Well, in hemifacial microsomia.
Yes, how to keep the condyle on the position.
In hemifacial microsomia case, the joint is of course difficult to keep it, but a good trick is if you want to keep the condyle position exactly the same during the surgery, is what you do is you make before the surgery you make a wax bite. And then when the patient is on the surgical table, you put in a wax bite and you put the patient in IMF. And then you take a long plate and you fix the plate to the mandible and to the maxilla. And this way you can fix the position of the TMJ relative to the occlusion. So after you do the BSSO and the 4-1 or whatever procedure, what you do is if you want to fix the plates or the leg screws, whatever, First, you reattach the plate to the maxilla, to the skull base, and to the mandible. Then you have the same position of the condyle at that moment as it was when he was in the normal occlusion. And then you can just fix your BSSO with plates or leg screws in exactly the same position as condyle position as before the surgery. It's a possibility. I usually don't do it. Usually I just manually place the condyle in the correct position. There is a slight discrepancy. Almost always when you have a class 1 occlusion during surgery, if you position it manually, post-surgery you will have a slight class 3, 1 millimeter. But for the orthodontist, that's usually not a problem. They actually prefer slightly end-to-end than too much of a class 2. So that's how I do it. But if you want to be certain of your condyle position, wax wide, during surgery, wax wide IMF, fix a plate to the skull and to the mandible, and during fixation, you reattach the plate, and then you're sure that that's the proper condyle position.
Okay, thank you, doctor. Still about the hemifacial microsomia. This is from Dr. Salem Al-Kalbi. How do you think we could manage the soft tissue loss of the affected side? And would you recommend to do a 3D print titanium implant to fill the angles, the angle instead of BSSO?
It's a possibility. But you're talking relatively young patients, and you're playing implants there for the rest of their life. And as you well know, with hemifacial microsomia, it's an illusion that you will ever get them perfectly symmetrical. It's never, never, ever going to happen. So even if you do 3D printed implants of the mandibular angle, it's still not going to be symmetrical because the soft tissue is going to be deficient. So yes, it's an option. It's a very, very, very expensive option. And it's also risky. You're placing implants. I've placed peak implants for that purpose, mandibular angle, but some of them get infected. And you're talking about relatively young patients who will have dental procedures and will have local anesthesia, chances of cross-contamination. I would be really, really hesitant to do that in such young patients. But of course, if you can't get the movement with the BSSO, an implant is a possibility. But it's really expensive. You're talking about, for those types of implants, you're talking about $10,000 US just to make the implant.
So it's a very expensive option.
Sorry?
It's a very expensive option then, doctor.
Yes, only people from the Arab Emirates can afford that.
Okay. Well, thank you very much. I think that's already clear. We're moving to another question. This is from Dr. Faisal. The questions is for both of you. The first question, what is the principal goal of the pre-surgical orthodontic? And when we decided to begin with the surgical approach? And then for Dr. Malvin, if there's a cases that we have to move the maxilla backward, is there's any tips from you? And in the BSSO, why the anti-clockwise rotation usually relapse? That's all.
Sorry, 5 questions. Yeah, it's better. What is the goal in pre-surgery orthodontics is to what we say, yeah, it's like we yeah, like we said before, so level align the teeth and only to make a good surgery possible. So that is make class 1 occlusion possible, have preferably 3-point contact, so in the front and in the on the sevens. And with that I mean 3-point contact on the whole jaw. I saw a question about 3-point contacts between teeth somewhere in the Q&A area. That's not what I meant. I meant the 3-point contact, so only in the incisors and on the second molars. So no interferences, transverse in the sagittal way. The two arches fit exactly on each other the way you want them to have. And in that stage, you can reach it relatively fast, usually, when you don't have to close extraction spaces or some big movements like that. You can achieve it relatively quick. So that's the goal for the orthodontic treatment prior to the surgery. What was the second question?
Yeah, and the second question is when to start with the surgery is when there's no more interferences. When interferences are gone, then it's possible to go ahead with the surgery. And as he explained before, when the position of the front teeth is in the correct position, so you know how far to move the mandible forward. And the second question is what is the tip when you need to move the maxilla backwards? The first tip is don't do it. It's really, really difficult. And I have actually never ever met an indication for moving the maxilla backward. If we have to move the maxilla backwards, it's easier to just extract two premolars and get the front teeth backward orthodontically. If you do want to move the maxilla backward, what you have to do is you have to remove the bone, the pterygoid bone. Behind the maxilla is the processus pterygoideus. And so if you want to move the maxilla backward, it hits the pterygoid. So you have to make an incision there and you have to remove the bone in order for the maxilla to be able to move backward. So it's possible, but it's really risky. And why? Because in between the maxilla and the pterygoid plates, there's the major vessels coming down from the skeletal base to the maxilla. Those are running there. So by removing the bone, you're risking hurting one of those blood vessels. And when they go, it bleeds like hell. And it's really, really difficult to stop. So basically, just try to avoid it. And the third, why is anti-clockwise rotation more prone to relapse? Two things. When you do anti-clockwise rotation of the mandible, what you're doing is you're stretching the suprahyoid muscles. And they start to pull back and they start to pull the mandible open again. This is the theory why it's more prone to relapse. If this is true or not, I'm not certain, but in my opinion, the main reason why anti-clockwise movement is less stable is we do anti-clockwise movement always in high angle cases. And patients, so in open bite cases, that's the only reason to do anti-clockwise movement. High angle cases, have much smaller TMJs. So they're much more prone to resorption of the condyles. So in my opinion, it's not that the procedure itself is more prone to relapse, but it's the patients we use that procedure are more prone to relapse.
Okay, thank you very much, doctor. It's very nice to see you both in one frame. Okay, so we have actually, there's lots of questions. So this is for Dr. Matisse from Dr. Andrew Laurent. Do you always use Barcelona line in every surgical cases, and how to make the line?
The Barcelona line?
Yes,
Okay.
the Barcelona line.
It's very easy to draw. You have the patient in a natural head position. So just have them preferably standing up, standing, and make a picture, a profile picture, and have them to take a point on the wall. But don't draw a point, draw a dot, because if you have a dot on the wall which is low, the patients go like this. And if it's up, if you have a small patient and the dot is on the wall is there, they go like this. So just have them look to a certain point, make a picture, and drop a line from sophnasium vertical to the floor. That's your Barcelona line. So it's very easy. Anyone can do it. Do I use it? Yes.
In presentations.
In presentation. I just use it. It's on my, if I have a good picture and where I have my pictures in the patient files, you can usually, if you have a nice, how do you call it? A computer program, you can easily put a raster. So you can easily put this line. So I just make the line and peek and see where it is more or less. But what's more important is to just use common sense. So what we like in faces today is much more this, like Angelina Jolie, and not the faces that are flat. Yeah. So so usually we don't bring maxillas back, like Melvin just said, but usually we leave them where they are or we bring them forward. Same holds true for the mandible. This
Okay, thank you.
It's a funny phrase that maybe not in Asia, but this Hernandez Alvaro that I told you about, the guy, the inventor from the Barcelona line, in class 3 cases that he operates, in 94% of his class 3 cases, orthognathic cases, he brings the mandible forward. Shall I repeat that? Because it's a mind fuck, so to say. In 94% of the class 3 cases that he operates, he brings the maxilla forward, but in 94% also a little bit forward the mandible, because he has to rotate. He has to rotate a little bit, so it's a bimax, but in the end, the chin is a little bit more forward.
Oh, okay.
So we like those faces, full faces.
Okay. Okay, thank you very much, doctor. Interesting. We have to catch up for another questions. This is from Dr. Dwayne Rehata. Is there a way to minimize the uncontrolled result from activator appliance post-treatment? I think you already answered this. Can you explain why you make 3-point ondulation on canine and premolars for Dr. Matisse?
3-point contacts.
Yes, 3-point contacts.
Yeah, I make 3-point contacts, not on the premolars. Sorry, that was a misunderstanding probably. The 3-point contact that I mean is on the incisors and on the second molars. So one on incisor, that's 1 point, and the second points, the 2 other points are on the second molars. And the rest is not touching at the moment of the orthognathic surgery. So 1 point here, 2 points there. So not
Okay.
3-point contacts with cusps touching, you know? That's not what I meant. It's also very nice to realize, but that's not what I meant.
Okay, thank you. In orthodontic surgery protocols, do you finish or realign the malocclusion first, then surgery second, or on the contrary?
Well, we prepare the occlusion. We prepare the occlusion for the surgery and after the surgery. So not finish the case before surgery, not finish the case, but prepare it for the surgery. So you have 3-point contact, transfers, everything all right. And after surgery, usually what we do is this. So we close the lateral parts and we make a nice occlusion, canine guidance, and that's what we do after the surgery. So the 6 months that I need after the surgery, I'm just going to get a good occlusion, have all the teeth touch, have good interdigitation, and if possible, good canine guidance for your articulation.
Okay, thank
So
you, Doctor.
the finishing I'm doing after the surgery.
Okay, so the thing that we hear the explanation is about the cases where we do the orthodontic first. What about the cases with the surgical first consideration?
Yeah.
In some cases, some oral maxillofacial surgeon, they do the surgery first, then continue with the orthodontics. What do you think about this consideration?
Well, surgery first is only possible in selective cases. If you have a lot of interferences in the, like he mentioned, if you want to do a BSSO and you have a lot of interference on the cusp and on the premolars, you can't do it, because if you move the mandible forward, you either have to choose between an open bite in the rear or an open bite in the front, which are both very difficult to treat orthodontically. But if you have the proper curve and you can move forward, and also the width is already correct, then you can do surgery first. So there's a few surgery first is only in selected cases, in my opinion. You have to be able to move the jaws in the proper position. You have to have no interfering contacts. Yeah, basically the interfering contacts are the most important. If you can move the mandible into occlusion without interfering contacts, then you can do surgery first.
Okay, thank you very much, Doctor. Moving up to next question. This is from Dr. Ahmed Setiabakti. I have patients with class 3 skeletal who have undergone orthodontic compromise treatment that forces the maxillary dental position to tend to be class 1 to produce a skeletal bimax shape. How orthodontic surgery plan, in your opinion, with this case?
Sorry, one more time. You have a dental class 1?
So this is the patient is initially class 3 skeletal, already undergone masking orthodontic treatment. So the maxillary become class 1.
The treatment is first orthodontic. You have to do the decompensation first. So you have to create, the best way is to create dental class 3 again, and then you do a Le4-1 advancement. That's the best way. If it's not possible or wanted, if you want to keep the occlusion as it is, you can do a bimax case where you move the maxilla forward and impact the posterior maxilla, and then you rotate the complex like this. So you end up with a chin in class 1 position. But the nicest way is just to redo the orthodontic treatment, create a dental class 3 again, and then do the surgery.
Okay, thank you, Doctor. So moving up, this is for Dr. Maningki from Dr. Rahmat Ritanga. In bimaxillary osteotomy, specifically the last patient in your presentation, which one you prefer, the maxillary first or the mandible? And the second question?
Okay, yeah, sorry.
Okay, the second question, by using face guide, do you still use the patient-specific splint? And do you conclude that PSI is mandatory for maxillary osteotomy? I'm going to take a picture of this for you. This is quite a question.
In Bimax cases, if you use the face guide system, you always do maxilla first, because you plan based on the maxilla. So you move the maxilla into the position you want it to, and the mandible follows the maxilla. So if you use the face guide system, you always go maxilla first. Is it still necessary to have the surgical splints? No, but it helps. The surgical splints make it easier for you to position the maxilla into the correct position. But sometimes during the repositioning, you see that the splint is wrong, and then you don't use it. So it's not completely necessary, but it helps a little. Is it mandatory to use patient-specific implants? No, of course not. We can do it the old-fashioned way. It takes me now. It takes me 4 weeks to do at least 4 weeks to do the planning. CBCT scan models, the planning, and for the company to produce the plates. And sometimes patients are put in between, and we just don't have the plates, and we do it manually like we did before, just by measuring. Of course, it's possible. It's less precise, but of course, it's still possible.
Okay, thank you very much. There's still another question. Do you do overcorrection to prevent the relapse after the orthognathic surgery?
Only in young class 3 patients. In class 2 patients, especially the low angle cases, you don't have to do overcorrection because it's not going to relapse. If you have a class E patient, so with the high angle cases, you might see some relapse, but maybe not. So it's no use overcorrecting, because you either get relapse or you don't get relapse. You never get a little bit of relapse. So, and if you do have condylar resorption, the relapse usually it's so much that you can't overcorrect that. There's too much relapse for overcorrection. The only cases I do a little overcorrection is in younger class 3 patients, where we expect some growth of the mandible post-surgery. So we create a slight class 2, and then in a few years' time, it will develop into class 1 usually. And even if it doesn't, it's possible to do dental compensation.
Okay, thank you very much, doctor. Moving to Dr. Stolpers, there's a question about which one the better of orthodontic appliance system to treat orthognathic patients before and after surgery. Is it H-Wise, Roth, MBT, Damon, etc.? So which one is you actually recommend?
Yeah, it's really a personal preference. It's really personal preference. What I use, but that's what I like, it's something that's very close to MBT, but I work bidimensional. So I have 018 slots in the front and 022 slots in the lateral parts. It makes sliding easy, closing extraction spaces easy. So I work with a bidimensional system, but let me look up where I saw this question.
Okay, wait a minute.
It's gone.
Oh.
No, it doesn't matter. I saw
yeah.
Damon users, it can be fine. it's a 22 slot bracket. I think a lot of patients or orthodontists in your area are using innovation brackets. They can be fine. So it's really the system is not that much important. It's more that if you're used to working with one system that you use for the other patients, use it the same way for your orthodontic cases. Just use your system that you have in your practice. Yeah.
The most comfort.
Yeah,
Okay.
exactly. The system that you're comfortable with, that you know the reaction of to the wires and everything. Yeah, yeah.
Okay, thank you, doctor. So this is a question about the extreme gummy smile, which need more than 8 millimeter to impact the maxilla. Do you think we have to combine with vestibuloplasty or any other thing that we should do?
8 millimeters.
Yes, with extreme gummy smile.
That is really extreme. But if you have extreme like that, the first thing you should do is check where does the gummy smile come from. A lot of the times it's not just the maxilla, which is maxillary hyperplasia. It's not the only thing. Often it's also the gingival hyperplasia. So we can do gingivectomy. But if you've done that and you still need more than 8 millimeters of impaction of the maxilla, honestly, I've never seen that before. But yeah, lip reposition procedure, I think this is what they mean with vestibuloplasty. I've done a couple of them, but they're really unstable. So maybe you will gain a little, but not very much by doing lip repositioning. But honestly, more than 8 millimeters of impaction for gummy smile, there has to be some sort of gingival hyperplasia, so deep pocket. So probably if you do a gingivectomy as well, you would resolve the problem partly. And as I said, you don't have to be perfect. I mean, a little bit of a gummy smile, and actually that's also cultural, but in the United
Leave
States,
the character of the face of the person, like you said.
Exactly. You don't have to go to the norm. You have to be careful with impacting the maxilla, because when the patient gets older, the upper lip will drop by itself. So if it looks good when they're 16 or 17, when they're 40, they will have too little tooth show and they will look old. So I've never done that kind of impaction, but
Okay. Okay, thank you very much, doctor. So it's quite limited option for the extreme cases, I think, but either way.
So you can combine the techniques, of course. You can do a gingivectomy, you can do a maxillar impaction, and you can also do the lip repositioning, maybe even with Botox to bring the lip down a little. That's also an option. But of course, Botox, it's also temporarily. You have to keep Botox for the rest of their lives.
So manipulate also the soft tissue to masking the gummy smile.
That's also an option, absolutely. Yeah.
Okay, thank you very much, doctor, for the explanation. From Dr. Inna Ibnu, how we can determine that one patient need the orthodontic surgery or maybe just the orthodontic treatment?
The main determinant is it a skeletal problem or is it a dental problem? Dental problem is for the orthodontist. If it's a real skeletal problem, then you have to consider, is the skeletal problem so big that you need orthodontic surgery? But the basis is skeletal or dental.
Okay, thank you very much, doctor. So we have to determine what is the main case of the malocclusional discrepancy first before decided I think. Thank you. Another question. Are there any effects that occur after maxillary and mandibular surgery on the temporomandibular joint? I'm going to add a little bit. If there's any, how to overcome the problem?
Especially in what you often see after mandibular surgery, that patients have trouble opening wide because of the different position of the TMJ. But those are almost always just temporarily. The biggest problem is, of course, condylar resorption. And this is always in the high angle cases, especially in young female high angle cases with a history of TMJ dysfunction. So, and the way to overcome this is not to treat those patients. So if we have a skeletal class 2 high angle case in a young female, and we see the x-rays and we see that the condyle is already very, very thin, then we basically say to the patient, well, maybe it's not you're not the right patient for orthodontic surgery. Maybe we should do try to mask the class 2 with or orthodontic treatment and chinplasty. Sometimes it's better to treat those patients.
Oh, okay. Thank you. Moving up to the next question. What's your opinion on using TAD instead of having the patient doing orthodontic surgery? The temporary anchorage devices.
Yeah, for treatment of class 3 patients. I have limited experience with that. In my experience, they have to wear those tats for a very, very, very long time. And I only have a few patients where they don't have trouble in between. Almost all of them lose one of the tats, or because they have to use them for years and years and years. I don't have very good experience with that, but of course the idea is, especially for small class 3 defects, the idea is good, it works. But in practice, you often see that the tats, they come loose, or they become infected, and you have to place new ones. And this means multiple treatments for relatively young children. And I've had a few of them come loose, and they say, no, I don't want it again. It's after they come loose once or twice, then they say, I don't want it again. And
okay,
they end orthodontic surgery anyway.
End up with surgery anyway. Okay, thank you very much, doctor. So another question. This is about the 3-point contact rule that previously explained by Dr. Matis. The first in the first point in the front teeth, and the second and third in the first molar on the left side and the right side. What should we do in case of jaw without molars in a quadrant or more?
Yeah, that's a good question, because I saw quite a lot of those patients in Indonesia. A lot of people, especially losing the first molars. So I was actually talking about the second molars, but some patients might have no molars. Very good question. If you don't have the molars, I usually go for the best fitting occlusion. So you have as many contacts as possible, in fact. So if you cannot make a 3-point contact with contact on the second molars and the incisors, just make it fit from 5 to 5, for instance. If you have the second premolars, it's really quite easy to make a real nice fit that all the teeth fit. So that in that case, you will have contact everywhere.
Okay, thank you very much. So there's another option if there's no molar.
If there's no molar, you cannot have that, but then you have contact on all the premolars. It's more,
Okay,
it's
thank
a
you.
search for the most stability. Yeah.
Okay, thank you very much. So, back again to the hemifacial microsomia. Which one do you choose to treat for these cases? Distraction osteogenesis or orthognathic surgery?
That's a difficult question. It depends on the case, but of course, if you have very large movements, you just can't do it with normal orthognathic surgery. But a lot of the things which have been claimed about osteogenesis is that you get growth of the soft tissue, that you get a more stable result. It's all not true. So if you can achieve the movement with an osteotomy, I don't see the point in doing distraction osteogenesis. But if the movement is so large that you can do it with an osteotomy, then of course distraction is a good option. But it depends on how large the defect is, the movement is you want to achieve. But if it's possible with an osteotomy, I would choose an osteotomy.
Okay, thank you, doctors. There's a questions about the complication after surgery. Is there is a more complication after? I think the question is about the severe complication after surgery. Could you share us your experience, and is there any cases when you have to do second operation? Perhaps for the example, for the last patient in your presentation to Dr. Maningki.
The last patient was
the cleft patient, I think the last is
the most redos we have is always in younger class 3 patients. So what you see in younger class 3 patients is that we still get mandibular growth up to their 25th. So usually if you treat them by the time they're 18, 19, 20, but they don't want to wait anymore. So you do the surgery, but you warn them, maybe you will end up with a class 3 again, and we have to do BSSO setback or LaFour-1 again. The severe complications, I would say in my hands none, but that's bullshit, of course. Especially in cleft patients, of course, what we are afraid of is if we do a LaFour-1, we get necrosis of the maxilla. And it's been described, I know one of the hospitals near Amsterdam, they had a case like this where the whole upper jaw became necrotic. It wasn't even a cleft patient, it was a healthy patient. So this is what everybody, of course, this is the nightmare scenario. But in all reality, if you don't push the envelope, if you don't, in cleft patients, you have to accept that maybe you cannot move the maxilla the desired 6 millimeters, but you can only do 4. I haven't seen it. Of course, it can happen. Of course, there's a possibility, but you can also die going outside, but with a car accident. I mean, you can't plan for things like that. So of course, this is what everybody is afraid of. This is what everybody's nightmare scenario. But in all reality, if you just stick to, if you work inside of the biological boundaries, you should be okay.
Okay, thank you very much, doctor. I'm actually a little bit curious with the last patients of yours, the cleft patient. I've been thinking about whenever you do the LaFour-1 osteotomy to the patient, because the patient was a cleft, bilateral cleft palate as well. So there's supposed to be an empty spaces at the in the maxilla, in the upper part of the maxilla. So how to overcome whenever you do the leftward one? I mean, there's supposed to be instability because the maxilla maybe will be torn to two part.
It's possible. Usually, most of, actually all of the cases have had a bone graft, so there shouldn't really be a hole. There should be a complete alveolus, but of course it's weaker, so you have to be careful. So but that's surgical technique. That's why in the Free University there's a lot of people doing the orthognathic surgery, but all the cleft patients are treated by me only. Especially if we do a L4-1, they're only treated by me. Because you have to be a little more gentle with the surgical technique. You shouldn't use the row elevators to do the down fracture. You shouldn't have too much tension on the upper jaw, because of course it can fracture. But that's more surgical technique. And even if it happens, even suppose it fractures, as long as you can put it back in the right occlusion and fix it, it should be okay. But gentle soft tissue handling, and especially in cleft patients, I use another incision. Normal L4-1, you do the incision in the opslagplooi in English. What do you call it? In the vestibule, you do a vestibular incision, but especially in cleft patients, I do an incision in the lip, so a little higher, so you get a lot of, you get more blood flow from the soft tissue, so you get a larger pedicle to keep it from.
The healing could be better as well.
And to minimize the chances of necrosis of the jaw.
Okay.
So
thank you very much, doctor, for the explanation. I'm being enlightened. Okay. One of our participants asking about the 3D software program that you use to predict the treatment that you're going to use.
We use several 3D programs. We use the KLS Martin, but the one I showed you is Face Guide. It's from Megagen.
Face Guide. Okay. Thank you very much. We still have lots of questions. A few more. Okay, 5 minutes left for the Q&A session. So what about the airway compromise whenever you do the setback mandible?
Yeah, that's why we don't use. That's why we don't do treatment of the class 3 with only setback. So what we usually do in class 3 patient is we move the maxilla as much forward as possible, or as or which is acceptable for the face, and then we minimize the setback. So we try to move the maxilla forward as much as possible to limit the setback because of airway issues.
Okay, thank you very much, doctor. Another question is, this is about the dentistry education. It is very interesting to learn that the perceptions of beauty has changed over time, and this affects the way we practice orthodontics and aesthetic surgery. How has this change been incorporated into dentistry education? Wow, it's kind of a little bit.
I'm not sure
this
how
is
much
about.
It is integrated in orthodontics or in orthognathic surgery cases. So like how I showed you, we had this Schwartz analysis from years ago, and now we have the Barcelona line. So we have the measurements change. The Steiner analysis on cephalometrics, well, hardly any orthodontics are still using them because they are done on white people. So it's not they're not international measurements. So yeah, it is incorporated and it is changing. For the same reason, we are, at least in Holland, hardly doing any setbacks of the mandibles in class 3 cases. We are moving the maxilla forward. It's all in this new beauty perspective. But yeah, but we can see if you go through ages, I can show you some in another presentation, some pictures of old paintings, and in ages, you look, it goes like this. It goes like this. Sometimes we like more flatter faces, and 50 years later we like more full faces. But it might change again. If you have a couple of superstars that have flat faces, probably flat faces are back into fashion again. Yeah, but we're using different measurements now than we did 30 years ago. That's a fact.
Okay, thank you very much, Doctor. It's a very great explanation. And we actually still have some question, but the time is quite limited because our schedule only until 10:30 p.m. It's very close. I would like to thank you once again to both of you. And for those who still have a question, because both of you already give the email to the participants, so I believe they could also send the email directly to you whenever they have a question.
Restaurant recommendations.
Oh, okay. So it's not for the question, it's for the restaurant recommendation. Okay, I see.
No, if someone wants to cook for us, it's also good.
Oh, okay. Thank you very much for your knowledge, for your sharing, for your experience sharing to us. It's been a very great time for us to enlighten our knowledge, and this is also educational. Thank you very much. I would like to ask a clap hand, but because this is virtual, so we cannot do that because you cannot see. Once again, thank you very much. And maybe for the closing statement, I would like to invite the Dean of Dentistry Faculty, Hasanuddin University, Dr. Muhammad Ruslin, please.
Thank you very much, Dr. Yosi. But I think we give to the Master of Ceremonial maybe before. Yeah, please, Dr. Isra.
Okay, thank you, Dr. Muslim. Okay, maybe we have to get to closing session. So thank you, Dr. Yossi, and thank you for Dr. Matis and Dr. Martin for the great presentation and discussion about surgical orthodontic treatment. The session was really inspired for our knowledge. Okay, ladies and gentlemen, this can finish participants. Now we come to the end of the webinar. For the closing statement, please, Dr. Muhammad Ruslin, for give our closing statement. The floor is yours.
And I would like to say thank you very much to my brothers, two big brothers. And now in Makassar, it's really already night now. So Huda Apon, and I hope we can meet again after COVID go on. And again, thank you very much for your contribution, for your supporting to our faculty to make successful in this virtual international symposium series. I hope we can do again for the next series with the other topic. And again, thank you very much, and really excellent presentation to both of you. Thank you very much.
Thank you. Thank you. Thank you very much.
Yeah.
See you soon.
See you soon. Tot ziens.
Yes. Next time, malam ya di Makassar.
Yeah, yeah. Sudah malam. Harusnya pergi makan sate dulu.
Thank you, Dr. Ruslin. So, ladies and gentlemen, allow me, Dr. Gigi Israyani, and all organizing committee to say thank you very much for your participating and attention in this Zoom meeting room and our YouTube channel. And for your information, like Dr. Ruslin information too, this virtual international symposium series will be continued next month with another topic, is maxillofacial prosthetic. Hopefully, we will see you again next month. So thank you all for your kind attention. So wassalamualaikum warahmatullahi wabarakatuh and good night.
Waalaikumsalam warahmatullahi wabarakatuh.
Right. Thank you. All right.
Gerut meneer. Perfect.
Dag vriend.
Yeah. Tot ziens.
Thank you, brother.
Yeah, thank you very much. Next time with nasi goreng, ya. See you soon.
Okay, see you soon. Bye-bye.
Yeah, you. Bye-bye. Doo-doo.